to start. It's my great pleasure to have you all here and to open this symposium entitled Parsing the Practicalities of Pathologic Response Assessment after Neoadjuvant Immunotherapy to Facilitate Progress in Early-Stage Cancer. It's my great pleasure to be here with you. My name is Solange. I'm leading the medical oncology in Lausanne, in a small country, Switzerland. But I will be with my colleagues today, and we will share this work to try to cover this important topic with Dr. Mark Awad from the Low Cancer Center for Thoracic Oncology, working at Harvard Medical School in Boston, Massachusetts, and Jonathan Spicer from McGill University in Montreal General Hospital in Quebec, Canada. All the three of us will try to help you understanding our questions, our interrogations, and our knowledge at the time being about neoadjuvant treatments across diseases, but with an accent, I must say, on specifically non-small cell lung cancer. So I'd like to welcome you all here, but also all the virtual attendees. We need to thank tonight PeerView, for providing this educational session, as well as Bristol Myers Squibb and Genentech for providing the educational grounds for this symposium. Please be part of this meeting, take part in the audience by answering the polls and also by asking and submitting questions. The easiest way for you in the room is to use the cards on the table that will be taken during the session in order to be discussed at the end. But virtually, you can also, of course, in the system, address through the Q&A part of your web. It's important for us to have your questions. We should have 20-25 minutes at the end to discuss them. The following slides will include accreditation and disclosure information. This is our disclosures. And last but not least, it's very important for you to know that you can visit the PeerView website and view the slides and practice aids now and download them after the event. It might be good to slowly look at them. It's a lot of slides and material. So if you need any more information, you can send an email, but you also know how to connect and to download all this material later on. Just to start this meeting, I need to ask you some demographic questions. It's going to be 4 questions. If you can answer quite fast, it helps us knowing who you are and also training the system. Please select your degree certification, and you have here 9 answers. You have 10 seconds to answer. My second question is selecting the category that best describes you, the professional category. Please select the one which fits you the best. The third question is to know about the patients you meet in your practice, in the care of approximately how many patients with solid tumors are you involved each month, and you have some averages. Please vote. And the last question, which of the following practice settings is applicable to you, academic, community, or other? Thanks for this last vote. Thank you. Then comes a question which are important for us and nothing demographic, but just to try to see how educational programs can support knowledge. And we'd like you to pose this question. You'll see several times to know how we can potentially move your answers from the beginning to the end of this session. How would you currently self-rate your skills and confidence in making clinical decisions regarding neoadjuvant and adjuvant immunotherapy in patients with early-stage cancers and using pathologic response assessment after neoadjuvant immunotherapy? And you can answer between no skills to excellent 1 to 5. Please vote. Thank you. We'll show at the end how it compares to the after-session survey. So today we have this aim of trying to recognize the gaps and opportunities for improvement of cancer care, trying to understand how resectable cancer include operational challenges and multimodality treatments that have to be addressed in clinical trials, however, are quite slow because overall survival remains the gold standard outcome measures for phase 3 trials and requires a protracted trial length in resectable cancers, making all the pace of what we do quite slow. And we'd like today to understand how we can expedite research and achieve progress. Innovation will be needed by potentially changing the endpoint by, for example, using PFS, but more importantly, potentially imagining that pathologic response might be a way to make the results and the practice changing faster for the best of our patients. We will highlight in this program today some foundational concept of perioperative immunotherapy. We will discuss the evolution of perioperative immunotherapy trials, as well as the question of surrogate endpoints. And last but not least, we will focus on what we have, the data of the 3 important clinical trials which today have been presenting, looking specifically at non-small cell lung cancer. And of course, at the end, the most important, your questions. So I will start immediately with the foundational concept of perioperative immunotherapy in resectable solid tumors. So again, just one challenge questions. How would you self-rate your knowledge and understanding of the rationale for neoadjuvant and adjuvant immunotherapy and the evolving role of perioperative immunotherapy in resectable solid tumors, from no knowledge to excellent knowledge? Please vote. Thank you. So let's move immediately to this rationale for immunotherapy. So first of all, we have been describing very early already in the course of the development of immunotherapy for solid tumors the existence of immune checkpoints. These accelerators or brakes that exist in front of the immune system or affecting the immune system and making the immune response possible or impossible in front of a cancer which is growing. And of course, you probably have seen all these names coming in publication as well as in phase 1 clinical trials for many of them, but we have to admit today, with the practice having to meet today, probably 2 or 3 of them, the inhibiting checkpoints, which are CTLA4, PD-1, PD-L1, LAG-3 with respective inhibitors. Of course, I don't want to go into details, but I'm sure you have been trying to manipulate OX40, GITR, TIGIT, TIM3 as being also potential modulators, but today it remains not practice and routine, so something just to be further studied. But it's very important to show some developments. But of course, we have spent a lot of time to find what we call biomarkers, meaning trying to understand who are these patients who present with an immunosensitivity, a tumor with an immunosensitivity, and these patients who present the characteristic of immunoresistant tumors. We have been defining these subgroups. I invite you to go through this wonderful publication, but you know many of these immunosensitive tumors have a high PD-L1, a high level of mutations, a high level of TILs, a high level of neoantigen, and an interferon gamma signature which is intact. Immunoresistant tumors have usually a lot of Treg, myeloid-derived suppressor cells. They have an IDO pathway activated, an adenosine pathway activated, and usually a very specific component of immune cell which is immunorefractory. Of course, in lung cancer, and again, not with a lot of originality in the way we improve the immune response or we strengthen the immune system, we've been mainly using anti-PD-1 and anti-PD-L1 as well as CTLA4. However, in lung cancer, all patients with metastatic disease will receive immunotherapy as monotherapy in combination with chemo or with dual immunotherapy, including a CTLA-4 component. But apart from the very defined field of oncogene addiction, all these patients with wild-type tumor have to receive immunotherapy frontline. So let's try how this data move to the early disease. So first of all, maybe to the adjuvant setting. What is the arguments to imagine to try to implement immunotherapy in the adjuvant therapy? So first of all, always the important fear we have is surgical delay. So putting everything in the adjuvant setting is avoiding surgical delay. Surgery following neoadjuvant immunotherapy has been thought to potentially be more difficult. We will discuss it later on, but of course it was a very thoughtful idea, or I would say concept, that had to be taken care of. We have proven benefit of adjuvant chemotherapy for stage 2 or 3, so we know that adjuvant can cure. And of course, based on the old days of vaccines, immunotherapy was thought to be more effective in the setting of very minimal disease burden, the minimal amount of cancer cells. Is it valid with checkpoint? I would say today we don't have data, but that was true at the time of the old days of vaccine, the early days of vaccine. Chemotherapy, it's what we get with adjuvant chemotherapy. Remember this latest meta-analysis, basically, and to make it short, across stage, what we would call today 2 and 3, you can obtain a 5-year absolute benefit by adjuvant chemotherapy of 5%. And we have been trying to add immunotherapy to adjuvant chemo. Remember this MAGE-A3 vaccine, which was done in the Magritte trial in resected patients, which unfortunately, despite a wonderful phase 2 with very promising data, the phase 3 was completely negative, showing that this vaccine alone after adjuvant chemo was not improving at all the fate of any subgroup of these patients treated in the Magritte trial. We tried and we failed. So, of course, now we have this new generation of immune, I would say, modulator, which gives rise to many clinical trials. These are the main 5 trials, where basically you face the same paradigm of having patients receiving surgery, being randomized after surgery, having more or less chemotherapy, but being randomized, to make a long story short, to 1 year of anti-PD-1 or anti-PD-L1. All of these trials have one of the endpoints being DFS. Some of these trials have co-primary endpoint being OS, or one of these endpoints in defined subgroup of patients, but DFS will be, I would say, the landmark of potential inter-trial comparison we shouldn't do, but we always do. So DFS is what is really being observed there. So with this new generation of adjuvant trials that I love because it brings science and maybe advances in what we do, is a generation of trials trying to understand who are the patients who, beyond surgery, beyond chemo, would need additional immunotherapy. These patients are the patients who still have disease, but only minimal residual disease, non-measurable disease. And this minimal residual disease, as you know, is a target of many trials, but can now be assessed by many methodologies, very competitive field. In the Alchemist trial, one of the exploratory endpoints is to look at DFS and OS in the patients with minimal residual disease as defined by circulating DNA. And in the MERBED-1 trial, the primary endpoint is the DFS in patients with minimal residual disease. So what we know is probably very clear across trial is this idea of minimal residual disease being a prognostic factor impacting the outcome of patients after surgery is quite clear. I will show you a table that's a concept which is quite clear. How can you manage or change this poor prognosis by acting in any manner, including adding immunotherapy, is still to be proven. However, what we know is the prognostic impact. Of course, CTDNA technique is not only improving because of the post-surgery setting, but also because we hope that technique will help us identifying an early detection of relapse, and also, of course, also monitor efficacy of what we do and potential resistance emergence, particularly with targeted therapy, but also with immunotherapy. But this is a table just summarizing for you this concept that having a minimal residual disease after surgery or after chemoradiation, let's say after radical treatment for early disease, is strongly prognostic. If you can change it, it's still a question mark, but at least you know it is prognostic. And this is a paper published 2 days ago in the Annals of Oncology, which looks at many serial samples of patients using first tumor exome sequencing, identifying private signatures, and using this and analyzed using patient-specific assays and showing, as you can see on the right-hand side, that this patient with residual CTDNA after surgery or definitive chemoradiation, and if you measure at the first time point after the end of treatment, whatever the treatment, and divide the patient between minimal residual CTDNA positive or CTDNA negative, you can see how the curves separate very easily on the left for survival, on the right for DFS. So can you act on it? Still a question mark, but at least it's prognostic. This is what we have as a concept of adjuvant. Let's go to the concept of neoadjuvant treatment. So first of all, we know since a while already that we could give neoadjuvant chemotherapy too. It is equivalent to adjuvant. There's only one randomized trial looking at it called the NAT trial, published a long time ago by Enriqueta Felipe. But this trial was showing, again, this absolute benefit of more or less 4 to 5%, but really showing that neoadjuvant chemo versus adjuvant chemo was giving the same benefit. Of course, this trial was slightly underpowered to detect very small differences, but what we could show in this technique and I would say way to manage patients, as we know also from the practice, is what you do in the neoadjuvant setting gives rise to a better compliance than what we do in the adjuvant setting. So maybe one of the benefits of any new neoadjuvant strategy might be the compliance to the treatment. But there are also some biological concepts that might guide you to maybe favor the neoadjuvant immunotherapy as compared to adjuvant immunotherapy. First of all, scientifically speaking, you can imagine that in terms of antigen load and release from potential dying cells into the circulation, the propensity, the proportionality of this important, I would say, immune stimulators will be way higher in the neoadjuvant than in the adjuvant setting, leading to a better priming of the immune system. Second, the fit host immune system and the fit host can be met in the neoadjuvant setting, and the problem of the compliance in the adjuvant setting is probably because of the detrimental effect of what you have done before. So you will meet in the neoadjuvant setting a fit immune system and also a host, which will be a patient who will be more eligible for whatever strategy. The clonal evolution is an important point. When you do anything against the tumor, being radiation, immunotherapy, or chemotherapy, you induce a lot of new mutations, secondary mutations, subclonal mutations, leading to a tumor which is less heterogeneous, and I will discuss it later on. Of course, you have an opportunity to accurately study the effect of immunotherapy by having a biopsy before and to assess and access the tissue in the surgical sample. And of course, you have an ability to access the efficacy of the therapy, the reduction of the presence of the tumor cells in the surgical sample, but also the radiological response. Of course, and we hope that neoadjuvant settings, that what we discussed today, might also shorten the time frame to complete the trial. Would we be able in the future to use a pathological endpoint as a surrogate of DFS or OS? Just to speak about the clonality of the mutation, remember this very interesting paper published from Nayer Rizvi in Science, showing that you can have some tumors with interesting mutation and a lot of mutation, but T cells look like to be reactive only to what we call clonal neoantigen, and that these subclonal neoantigens emerging upon chemotherapy, upon targeted therapy, upon immunotherapy are not able to give rise to a strong specific immune response. And this was nicely shown in that publication, as well as many secondary publications looking at tumors and clonality of the mutation. And on the right-hand side, you can see this last publication showing that tumor with a high clonal neoantigen burden and a low neoantigen heterogeneity have the most important probability of giving rise to an immune response. So that's probably why neoadjuvant naive tumor might be better for the immune system. The mice model has proven that, or at least comforted the idea and this biological model. On the left-hand side, it's a triple-negative breast cancer, spontaneously metastatic mouse model, where they compared neoadjuvant to adjuvant IO with a prolonged survival of the mice with a neoadjuvant IO as compared to adjuvant IO, and also correlated to this survival an increased level of specific tumor-specific CD8 positive cells in the neoadjuvant setting. And on the left-hand side, it's a mouse model, the non-small cell lung cancer OVA-positive murine model, which is a lung cancer with spontaneous lung metastasis, where they could see here again a better survival for neoadjuvant treatment in these mice models, but also a decrease in secondary lung metastasis by giving neoadjuvant as compared to adjuvant. So mice model did reproduce what the story in the biology would have made us think, or at least hypothesize initially. And we have some proofs. This is the first Patrick Ford paper in the New England, remember, 2 cycles of nivolumab in the neoadjuvant setting, and this wonderful picture showing that before only 2 cycles of nivolumab, you have a tumor which looks like a little bit an immune desert, with everything describing an immune response being absent, going after 2 cycles of nivolumab to a tumor full of CD8 positive and PD1 positive immune cells, really showing that this immunofluorescence, you can see that there are many new positive immune markers showing that you can give rise rapidly and efficiently to an immune response. And this is a big list of ongoing phase 3 neoadjuvant trials. We'll discuss a little bit about it today, showing you that this effort is being, I would say, currently undergoing in lung cancer. And you can see here the strategy is slightly different from what I have shown before, because patients are randomized before anything at the time of diagnosis to receive neoadjuvant chemo most of the time versus chemo IO, then is surgery, and then for most of the trial, it's a continuation of the IO for up to a year, except for one that we will discuss later on, but all the other ones continue to up to a year. All of these trials have an EFS endpoint, but some of them have also a pathological endpoint that is very interesting, and that's what we'd like to look a little deeper today. And beyond lung cancer, let's also maybe have a short look of what we have in hands as being prescribers, physicians, doctors in the main killers, for example. This is what the FDA has now approved in terms of neoadjuvant or adjuvant immunotherapy today. I will show you some curves later on. I think it can be helpful as a reminder. First of all, and it's going to be one of the topics later on, there was an approval very recently of neoadjuvant a treatment of nivolumab in resectable non-small cell lung cancer with platinum doublet chemotherapy. It represents the first FDA approval for neoadjuvant therapy in the context of early-stage non-small cell lung cancer. The first step is nivolumab. Look at nivolumab. You can also give adjuvant nivolumab in patients with urothelial carcinoma who are at high risk of recurrence after radical resection. You can give adjuvant nivolumab in patients with completely resected esophageal or gastroesophageal junction cancer with residual pathologic disease who have received neoadjuvant chemorad. And you can give adjuvant nivolumab in patients with melanoma, with lymph node involvement or metastatic disease who have undergone complete resection. Remember, in melanoma, that is this very specific definition of fully resected melanoma, even if metastatic. For ipilimumab, you can give ipilimumab again in melanoma in patients with lymph node involvement, significant lymph node involvement, but no metastasis there. Pembrolizumab can be given in the triple-negative breast cancer context in combination with chemotherapy and again with continuation of pembrolizumab up to 1 year. It can be given in patients with renal cell carcinoma at high risk of relapse following nephrectomy or following full resection of metastatic lesions. You can give pembrolizumab in the adjuvant treatment of melanoma, but not only stage 3, but also stage 2 now, 2B and 2C. And you can give, I would say, adjuvant pembrolizumab or pembrolizumab in the context of this specific early disease, patients with BCG unresponsive, high-risk, non-muscle invasive bladder cancer who are not eligible for cystectomy. And last but not least, atezolizumab can be given in the adjuvant setting of stage 2-3 non-small cell lung cancer following chemotherapy in patients with tumor PD-L1 positive. This will be discussed later on. Some curves for you. Remember this urothelial carcinoma. These patients have tumors at high risk of relapse, T3, T4, or N positive, or have received potentially neoadjuvant cisplatin with after neoadjuvant cisplatin T2, T3, or N positive disease. And they are randomized for this adjuvant nivolumab. And you can see there were two co-primary endpoints, DFS in ITT or DFS in PD-1 positive tumor. And giving 1 year of nivolumab was improving both DFS, both endpoints in this high-risk urothelial carcinoma, and it's now a standard of care. So second, esophageal gastric cancers. This patient received chemoradiation, radical chemoradiation, for stage 2 and stage 3 esophageal or gastroesophageal junction cancer. And they present with remaining tumor being T1 or more or N1 or more, and these patients can receive 1 year of adjuvant nivolumab. And in this patient, you can see this hazard ratio of 0.69 after 2 years of follow-up, again giving rise to a standard of care of this patient who cannot present with a complete response after radical chemorad. Breast cancer, a large field of research, and of course, a lot of patients. You know that now neoadjuvant chemotherapy is proposed to patients who have tumors which are large or which are nodal positive, T2, T3, T4, and 1. And in that context, it was given pembrolizumab in combination with carboplatin and paclitaxel, followed by cyclophosphamide and doxorubicin, the usual 6 months of chemotherapy, and pembrolizumab was continued for 1 year. And as you can see, there were two co-primary endpoints. The first one was complete response, pathological complete response, and interestingly, in breast cancer, in triple-negative breast cancer, it's quite interesting to see that PD-L1 doesn't count. You can see the same improvement in complete pathological response in PD-L1 positive or in PD-L1 negative. So this is not a biomarker there. And you can see this New England published last year by my colleague Peter Schmidt showing you a very important, for breast cancer, it's a very important EFS improvement of almost 8%. Is still immature, but already showing some difference to be observed. So very important triple-negative breast cancer, 1 year of pembrolizumab, 6 months before, 6 months after, and the usual neoadjuvant chemo. Renal cell carcinoma, these patients who have these tumors intermediate high risk or have metastases which have been fully resected. In the New England paper, it's only 6% of them who were metastatic, but you can already see here a very important DFS benefit of 0.68 in favor of 1 year of pembrolizumab in the adjuvant setting. Again, survival is immature, but you can guess how the curve is moving over time, and always maybe imagine some benefit to be observed. And then the large field of melanoma. Melanoma in the adjuvant setting reproduced quite a lot what we have been seeing in the metastatic setting. So first we compared ipilimumab versus nivolumab. And like in the metastatic setting, nivolumab is better than ipilimumab. But remember in that trial, ipilimumab was given at 10 mg per kg, which we would not do anymore now, also giving rise to potentially not manageable toxicity or difficult to manage toxicities. Then we continued to move with some hopes in trying to give dual inhibition, like in some patients we do in metastatic melanoma with ipi-nivo. This is a very negative adjuvant trial where ipi-nivo was not better than nivolumab monotherapy, but for the first time, the colleagues of melanoma decided to use ipi-low dose, 1 mg per kg. So some think that it might be one of the reasons this trial is negative. Maybe the other reason might also be that the toxicity of ipilimumab was so high in the adjuvant setting that the drug exposure was extremely reduced, very short, and maybe only the intensity of the experimental treatment with ipilimumab was too low to really show a difference. And very disappointingly, the ITT population, as well as the most interesting one, the PD-L1 negative populations, both are completely negative. And of course, you also have pembrolizumab in melanoma. With this nice trial, this is the first trial performed in stage 3, showing that 1 year of adjuvant pembrolizumab in stage 2 are giving rise to an amazing hazard ratio of 0.56. And you have seen at ESMO last year that a same trial, it is the keynote 6726, was showing a benefit in stage 2 also. So even more early disease, almost all melanoma patients could receive now 1 year of pembrolizumab with the same kind of hazard ratio in that setting. We will have to refine everything we do, particularly in the adjuvant setting, by using the best biomarkers to select the patient who can benefit from receiving up to 1 year of treatment. This is something we have not been very, I would say, successful in applying to advanced disease, despite this long list of approved biomarkers called immunotherapy, immune biomarkers, but really not having met the daily routine practice, maybe with the exceptions of PD-L1 immunohistochemistry, and for some of you, MSI and maybe TMB. So, of course, we need to move forward with biomarkers to try to make sure, beyond cell-free DNA, circulating DNA, but beyond circulating DNA, who are the patients who can specifically benefit from an immune stimulation according to their phenotype and the genotype of the tumor. Of course, to bridge with the next talk, we need to keep in mind that the assessment of what we do in the neoadjuvant setting can be done looking at OS, but many adjuvant approvals have also been based on disease-free survival. Think about what I presented before. Trials in neoadjuvant setting provide an opportunity to potentially even make it better using and assessing pathological response as an early surrogate marker for survival outcomes. And you can see, if you look at your PubMed, there are many trials now, for example, in breast cancer, correlating very strongly the pathological response with OS and PFS, making it very strong. In lung cancer, we have been using two definitions of pathological response: the pathological complete response, with the absence of viable tumor cells, but also what you call the MPR, the major pathological response, pathologic response, which is the persistence of less than 10% of viable tumor cells in the treated tumor bed. So something which the pathologist should understand, we hope it is the case, as being a definition of a dramatic response to the neoadjuvant immunotherapy or chemotherapy. So we have major efforts ongoing to try to standardize this pathologic assessments, particularly looking at MPR. And my last slide is just to show you how the societies, and here it is the International Association for the Study of Lung Cancer, how these societies try to give guidance to pathologists in order for them to use the same definition of MPR, major pathological response, trying to illustrate how you count it, right? What are viable cells, what is necrosis, what is the stroma, in order to make sure that there's no discrepancies between the way we try to create a surrogate endpoint for neoadjuvant immunotherapy. With this being said, this definition is one in the middle of some definitions also sometimes defined by the clinical trials and the protocols, but at the end of this definition, we will have to be able to make sure that the correlation of MPR and other outcomes is established, as well as pathological response, particularly in lung cancer, where it's still not the case as compared to breast cancer, for example. And with this, I would like to go to my challenge questions to end this talk, to try to know is based on what you learned, how would you now self-rate your knowledge and understanding of the rationale for neoadjuvant and adjuvant immunotherapy from no to excellent. Please vote. Okay.
Thank you, Dr. Peters. Oh, I'll have this one here. So that was an amazing tour of everything that's happening in peri-adjuvant therapy for a number of malignancies. It's a great honor to be here today to speak to you about one of my favorite topics, which is perioperative immunotherapy for lung cancer and how it relates to how pathological response influences what we do. So we'll start again with the challenge question. How would you currently self-rate your knowledge and understanding of the challenges in conducting multimodal perioperative immunotherapy trials, the role use of surrogate measures such as pathological response assessment, and the importance of multidisciplinary collaboration to facilitate progress in this area?
It's very difficult to understand the column.
All right. So I think Dr. Peters covered this. It's not a new concept to give systemic therapy before surgery for locally advanced early stage lung cancer. This is one of the two pivotal trials in the early 90s showing a dramatic overall and disease-free survival benefit to the addition of periadjuvant chemotherapy for stage 3 patients. In fact, this study had to be stopped early for ethical reasons because the effect was so strong. So for a long time, we've been thinking that this is an important thing to do. And yet, when we look at the adoption of neoadjuvant therapy in the community for lung cancer specifically, it's very rare, in fact, in North America that anyone uses it, and it's probably true for the rest of the world as well. But you also see the significant number of patients who would normally be eligible for adjuvant therapy, and you've heard of the benefits, don't actually make it to treatment and will be treated with surgery alone. We've covered this. We know that whether if you were to choose between one or the other, it's not going to be because one gives better or worse survival benefits. They're equivalent in that regard. But we have some very interesting data, and this was just published last month from the Alchemist trial, which you've heard regarding the design. It's a large study. We've looked at 2,833 patients who underwent resection and tried to see if what happened to them in regards to what is the standard of care, adjuvant cytotoxic therapy. And only 57% of those patients actually made it to adjuvant chemotherapy, leaving a significant number undertreated. Of those, we only have 44% who completed 4 cycles. So the compliance issue is a real one. And with regards to what is the guideline concordant choice of chemotherapy, which is cisplatin-based chemo, only a very small proportion actually get that. So while we know this works, we can hardly get patients to get the well-documented standard of care. And the reason for that is that it's fairly toxic. And my choice when I see my patients in clinic and why I encourage them to adopt a neoadjuvant strategy is in relation to the tolerability. This is a study from Sloan Kettering. I would think if anyone can give safe chemo, it would be the folks at Sloan. And even in their hands, they had twice as many grade 3 adverse events in the adjuvant-treated patients versus the neoadjuvant-treated patients for the same survival outcomes. So that's just conventional chemotherapy. What if we add modern therapeutics like tyrosine kinase inhibitors or immunotherapy? Well, I don't want to be a naysayer about adjuvant therapy, but the signals aren't dramatic. We're not seeing wide splaying of the curves in this regard. It's immature data, granted, but with median follow-up approaching 3 years, we'd like to see better differences. So when I think of how I can improve the care of my patients, I like this process map to sort of figure out where I can make inroads for our patients. And I'll just talk about surgery briefly here. That's what I do. I'm a surgeon. I happen to have trained and work at the place where the first pneumonectomy using individual hilar ligation of the vessels and bronchus was performed at the Royal Victoria Hospital in 1933. And if you read this paper, you should sit down because before they made it to the first successful one, there were a lot of on-table deaths and disastrous outcomes. It's not a great operation. And I think still to this day, although we've made a lot of progress, surgery remains the highest risk portion of the patient's trajectory with early stage cancer. This is what a pneumonectomy looks like today when done through a standard thoracotomy. It's an invasive procedure. There's serious complications, chronic pain issues associated with it. And although we're able to do minimally invasive surgery, this is a relatively simple case, a small tumor. We can go through a single incision. We do nerve blocks for good pain control. We can dissect all the lymph nodes, remove the lobe safely. The patient goes home in a day or two. It's still a high-risk procedure. Patients can bleed. Patients can have complications. So we would like to mitigate the risks of surgery, and this was a study that really dictated the management of locally advanced lung cancer done in the early 2000s, where it was investigated whether surgery could be avoided altogether for stage 3 patients, where they would be treated with concurrent chemoradiation and then randomized to either surgical consolidation or not. And while there was a disease-free survival signal, benefit there, the hazard ratio for overall survival was crossing unity and was called a negative trial. And yet, this was a post hoc analysis. When we looked at surgical toxicity and how that influences the long-term outcomes of patients, it's a very real phenomenon. So patients who had a lobectomy, removing a more conservative amount of lung, had significant benefit from the addition of surgery, whereas those who had pneumonectomy had significant harm. So this influenced the thoracic surgical community quite significantly because we realized that what's given before can really affect the outcomes from our operations for our patients, and certainly we were not interested in harming them. But we knew for a long time that pneumonectomy is a bad operation. It's associated with much higher mortality rates, much more death from non-oncologic causes. So even though you feel like you may have better resection margins, better oncologic control, patients die of pneumonias, myocardial infarctions, and other complications because it's nice to have more lung. And one of the greatest advances in surgery, in thoracic surgery over the last 20 years, has been the adoption of more complex resectional techniques like sleeve lobectomy or pulmonary arterioplasty, specifically to preserve the lung. And this is a study down one of the biggest and most busy thoracic surgery centers in the world at the Shanghai Pulmonary Hospital, where they show that there is a learning curve to knowing how to do these operations, but you can achieve excellent outcomes by adopting these techniques that aren't detrimental to the patient in terms of oncologic outcomes. And part of the reason why I'm keen to talk about organ preservation in surgery is that we have some interesting signals. This is probably one of the most pivotal studies that's been done for stage 1 lung cancer in decades from the Japanese cooperative group, where they randomized 1,100 patients to either lobectomy or segmentectomy, where we're removing a sub-portion of the lobe in an anatomic fashion. And stunningly, this surprised most people, the survival seemed to be better with the patients who had a segmentectomy, despite almost twice as many recurrences locally. So there's something to having this vital organ inside you and not in the pathologist's office. And while that is kind of revolutionary in thoracic surgery, it's not a new concept for breast cancer. That people have been trying to de-escalate surgery for breast cancer for well over 100 years. And that's been enabled largely by the excellent trials that were done, but also by the application of systemic therapy, and neoadjuvant therapy has been a pivotal part of that. This is, again, going back to the results that Dr. Peters was talking about. If half your patients with conventional chemo have a path response, maybe they don't even really need to undergo surgery, and now it's close to 2/3 when you add pembrolizumab who have a complete pathological response. So it's very thought-provoking about maybe there's a medical cure taking place here. And in fact, oncologists in the breast space have started to design trials to investigate whether that can be done, but the key step is being able to predict the event of pathological complete response. If you can't predict that happens, you can't really safely assign a patient to non-surgical therapy. A lot of what we've talked about in the early stages has not benefited from all the great work that's been done in stage 4, where we've really shown that if you enrich for good biomarkers, you're going to get better results. And this is an example, one of the few in the early stage space, looking at colorectal cancer in patients who have MMR deficient early stage colorectal cancer receiving IPI and Nivo, that 19 out of 20 patients got a major pathological response. That's stunning. Maybe it's like a colitis. You treat it with antibiotics with a short course of medications and you've cured the patient. Extremely thought-provoking. Now, lung patients often have a lot of comorbidities. They're smokers, not infrequently. They have a whole bunch of other things that can lead to complications during surgery. And we know in the upfront surgery space that when we have take a bit of time to prehabilitate them, give them exercise programs, improve their nutrition, prepare them psychologically for the operation, we improve their general health, physical health, mental health, and this leads to shortened hospital stays for the patients. This is a randomized trial that was done at our hospital. So in that setting, we have a problem where if we don't operate on them quickly, we have this unchecked cancer progression and fear for development of metastasis if we wait too long. But there is benefit in terms of improving their fitness during that time so we can perform safe, effective surgery. We've been pretty aggressive in terms of adopting neoadjuvant therapy at our hospital, and this is just a small study with a few patients, but what prehabilitation seems to do when it's concurrently administered with neoadjuvant therapy is at least maintain the functional status of the patient, and what we seem to see is that their length of stay in the hospital is quite a bit shorter. So we really think there's something to this. And what's very important when you approach a patient with this is they're not waiting for surgery anymore. They're preparing for surgery. They have a strategic plan. They're addressing their potentially micrometastatic disease. We're shrinking the tumors with these highly effective treatments, and we're coming to surgery in the most prepared ways that we can be. We're not in a rush to get them fit in 2 weeks. We have 3 months to get them ready, which is usually ample time. If they're smoking, we can get them to quit smoking. If they're malnourished, we can get them to improve that as well. So really, it's out with the old, in with the neo, and I think that's how patients ought to be treated. So how effective are these regimens in non-small cell lung cancer? Well, Dr. Peters hinted at Patrick Ford's and colleagues' really pivotal study showing a 45% major pathological response with just 2 doses of nivolumab. I mean, that's amazing. If you were to give 3 cycles of chemo on average, maybe you'd have a 15% MPR based on historical studies. So it was really quite a significant advance. If you added chemotherapy to that, this is Dr. Shu's study, it's not just MPRs that we're seeing. A significant proportion of the patients are having complete pathological response. This is stunning, stunning data. I remember when Dr. Provencio showed his data from the Spanish group's trial, the Nedim trial, giving preoperative chemo-nivolumab at World Lung in 2018. I thought I was going to be out of a job. I mean, I might still be out of a job, but 63% PCR is a big deal. And you're seeing the patients who never made it to surgery living long without disease. Maybe those patients had PCRs too and were cured. Extremely thought-provoking data. And when we look at now we have 3-year survival data from the Nedim trial, half of these patients had multi-station N2. In most hospitals around the world, that's unresectable stage 3 disease, not because we can't go get those lymph nodes, just because people feel that it's not fair to put those patients through surgery. But look, they're doing great. 82% overall survival. No one would ever think that that would be the case for stage 3, not me 5 years ago. So this is really, really a big deal. But we have a problem as surgeons. We don't know what we're dealing with when the patient comes to the operating room. It's a black box. I didn't go through this for sake of time, but none of the radiographic data really helps us know if the patient has had a complete response. And traditionally in thoracic surgery, we're to resect the tumor bed because we don't really know if we're going to leave disease behind when we don't. Now, this team in China looked at, this is off-protocol, real-world data from giving chemoimmunotherapy prior to surgery. And I think what's really impactful is that this short course of treatment really impacted, now it's not prospectively collected data, but it seems to have really impacted what they thought they would do and what they actually had to do. So you see far fewer pneumonectomies getting done, far more lobectomies, and that, like I said, is a big deal for patients on its own. And in their hands, they had a lot of patients get complete pathological responses. The dark blue columns are patients who only had 2 cycles. So maybe we can tailor the preoperative regimen if we really had a good way of knowing who had a complete response so we can de-escalate or escalate accordingly. And 3/4 of those patients had minimally invasive resections, and that's valuable to our patients as well. So what about prediction? What if we knew that we had a PCR? Is surgery still required? Can we consolidate by other means with radiation? Would that actually be less toxic to the patients? Can we tailor the surgery? If we do tailor the surgery, are we compromising the R0 resection rates, which we know, at least with what we know up to now, is important? And how do we optimize long-term morbidity while minimizing the morbidity of the treatment itself? This is great data from the LCMC3 trial where 2 doses of atezolizumab were given before surgery, looking at CTDNA by Dr. Chris in ESMO last fall. And I think the graph on the left is compelling. Look, the CTDNA levels just incrementally go down with those 2 doses, and then thankfully there's good news. Surgery still helps as well to remove whatever minimal residual disease might be circulating or being shed. So again, very compelling data here. The technology, as Dr. Peters hinted to, is rapidly evolving. This is a Bioarchives study from Dan Landau's team, where again, the neoadjuvant trial of low-dose radiation and immunotherapy that Dr. Al-Torki devised was leveraged for discovery, again showing that this highly sensitive method of detection using whole genome sequencing is extremely helpful in terms of tracking the evolution of disease. And again, I'm relieved to see that the curves go down further after surgery, and I still have work to do. The Neostar Trial is just a fantastic example of how translational science can emerge from a neoadjuvant platform. I really think it's unparalleled in terms of scientific discovery. We're corroborating the findings around T-cell receptor richness and clonality and how these things influence pathological response. The microbiome seems to influence immunotherapy-related complications, but also pathological response. And these are not just things that are biomarkers of response, but things that we can take action upon. And I think in a structured prehabilitation model, we can implement nutritional supplementation and exercise that can also influence a lot of these factors. We're very interested at McGill in multiplex molecular imaging. We've used imaging mass cytometry to characterize lesions. It's highly specific, monoclonal antibody-directed molecular imaging with up to 40 targets on a single slide. Just for representation, I'm showing you 7 here where you can layer all these things, and then we've developed the algorithms for cell segmentation analysis so that you can assign lineages to these cells and look at the neighborhoods that are interacting with each other. And when you apply machine learning to these samples, we hope that this will be out sometime in the near future, we can predict progression for early stage patients with an AUC that's well above 0.9, close to 0.95. So what if we use this kind of technology on biopsy specimens to predict response to immunotherapy? The impact could be dramatic. But all of this will require convergence of multiple tiers of data. It's going to be complex. No one thing. Maybe the radiology is important, but only if you add the CTDNA and some other factors to be able to predict response. And so we need some mathematicians and computer scientists to help us. So the scientific opportunities are there, but really I want to close with a couple thoughts about our teammates in the care of patients. So the pathologists right now are truly our unsung heroes. They're down in the lab. We don't get to see them. The patients don't get to see them, but they really help us understand what's happening with our patients. It's always been true, but it's truer than ever now. This is a patient who had a very large tumor. You can see in his left lung, it's invading the pulmonary artery. We treated him on a chemoimmunotherapy protocol, had a partial response radiographically, and in the OR you can see my feeble attempt here to try and save the lobe, but it was just all fused on the pulmonary artery. There was no way not to take his whole lung. So we did a pneumonectomy. Fortunately, he did well. He was a fit patient, was prehabilitated, and this is the specimen. So now we know that maybe a quarter or up to 2/3 will have no residual disease. The pathologist has to start looking through this and confirm whether that's true or not, because that may have prognostic and maybe therapeutic implications for the patient. I have phenomenal pathologists. I love them. They're my favorite people. And this is what Pierre said. He went and looked through all of these blocks, and he found one little focus here of disease, 0.3% viable tumor cells. And he didn't stop there. He sent this for next generation sequencing and found that the patient had a MET exon 14 mutation. That's valuable information moving forward. Maybe this will always be sequestered. Maybe we had given another round of treatment, it would have all disappeared, but maybe this is going to show up in his bone or brain in a year or two, hopefully not. But again, very interesting information that's gleaned from these efforts. But you can only imagine the time it takes to assess that specimen, and we need better technology to support the pathologist's work. And this is work that's being presented at this year's AACR by Janice Taub's team from Johns Hopkins, looking at machine learning to assess pathological response, understanding that response is existing on a continuum. And MPR was chosen just because PCR was such a rare thing in lung. It was like 5% of patients, so you couldn't really design a trial based on it. 10% MPR was a more reasonable endpoint. But now we're going to have pathological response existing on a continuum. The final thing I'll talk about is the importance of building a team. And the man on the left there is Dr. Mulder. He's my surgical mentor. And about 15 years ago, he started this lung cancer navigation team because we understood that patients had to go through an enormous amount just to get to treatment. And once they had a diagnosis and a stage, it was, no one path was clear. Patients have a number of options open to them. And what was really important is to get the team around the patient live when you're seeing them so that they can be assessed fully and be offered the best possible care. This is just a sample of what a patient might go through. You know, they'll have a CT scan, and there's a tumor, they'll go see a pulmonologist. After arrange a PET scan, now we need to do some invasive imaging, invasive staging, sorry. That small biopsy needs to manage adequately, there needs to be sequencing, then they get discussed at tumor board only to realize, oh, we don't have a proper biopsy for that patient to be enrolled on a trial. Back to square one, another biopsy. If they agree, then you get them to sign consent and stuff has to get sent off. Anyways, it's insane what we have to do. So what we implemented to facilitate that process is these navigation rounds where the therapeutic team comes and gets involved at the earliest point in the trajectory so that we can determine, is this patient interested in a trial? Can we set them up and make sure that their whole diagnostic and staging trajectory is aimed towards what the most likely best therapeutic plan is for them that fits their wishes. So that's been very valuable. And what is multidisciplinary care? Well, all the disciplines are more or less, I'm sure I'm missing some here, but most of them are represented here. But most places will work in a siloed fashion where the patient will travel from one clinic to another to go through their care, and the arrows go back and forth because they might go back and forth through all these different places before they finally make their way into survivorship mode. But I think the more we can bring all these different teams to the patient in a consolidated, dedicated lung cancer clinic, I think it's extremely valuable. I think teamwork isn't easy. Let me tell you, it's been a challenge to set this up in my place. Doctors aren't always, willing to sit in a room and get along with everyone. But it's been extremely rewarding and valuable, and I think there's a lot to be gained from it. I don't know if this is for me. Okay, so I'll ask you a challenge question, post question based on what you just learned. Would you now self-rate your knowledge and understanding of the challenges in conducting multimodal perioperative immunotherapy trials, the role, use of surrogate measures such as pathological response assessment, and the importance of multidisciplinary collaboration to facilitate progress in this area?
This is it's not intuitive.
I'm not sure whether you guys learned anything, but I'm sure you will learn something from Dr. Awad.
I'll see if we can rise to that occasion. All right. Well, it's a pleasure to be here. My name is Mark Awad. I'm a thoracic medical oncologist at Dana-Farber in Boston. It's very nice to see you all in person. And as we've been seeing some of these major phase 3 clinical trials read out in the neoadjuvant adjuvant setting in the past year or so, this has been a very exciting time. For early stage lung cancer, our standards of care really haven't changed much in the past couple of decades until recently. So we're going to spend some time reviewing the recent data, where do things stand today, and how have these trials already shaped practice. And for this section, we'll have this pre-question: how would you self-rate your knowledge and understanding of the data from key phase 3 neoadjuvant and adjuvant immunotherapy trials in resectable lung cancer, and how to interpret and apply these data to practice? All right, so we're going to fly through quickly since a lot of these data have been presented and published. But we'll start with the Checkmate 816 study, and we're very excited to hopefully see some additional data presented on Monday here at this meeting on the event-free survival data that have led to the recent approval in the United States. And for Checkmate 816, here's the trial design. So patients with stage 1B to 3A operable lung cancer were eligible. If they were known to have an EGFR or ALK rearrangement, they were excluded. And patients were randomized to chemotherapy plus nivolumab, and there was an arm of IPI plus nivo that was not carried out further. And here you can see the baseline characteristics of these 179 patients in each group, fairly well balanced by histology, smoking status, PD-L1 score, and tumor mutational burden. So a key question is, when you are spending this time in the neoadjuvant setting, are patients unable to get to surgery with this kind of approach, which is, of course, a big concern for all of us, especially with our surgical colleagues. And here you can see on the left is the patients who got nivolumab plus chemotherapy. 83% of patients received definitive surgery, 16% of surgeries were canceled. On the right was the chemotherapy control arm. And here you can see that there were more cancellations of surgery, 21% versus 75% receiving surgery. So it seemed that, if anything, the addition of immunotherapy to chemotherapy in the neoadjuvant setting led to more successful surgeries. And this was the key endpoint, one of the two primary endpoints that was presented at AACR at this meeting last year, which was the pathologic complete response rate. And this isn't something that we were used to talking about in lung cancer since it was so infrequent. But here you can see that the addition of nivolumab to chemotherapy increased the path-CR rate from 2.2% in the control arm, which is quite low with chemotherapy alone, to 24% with chemo plus nivo. So on the left here is the intention to treat population, including those individuals that didn't make it to surgery. On the right in the upper panel are the patients that did have successful surgery, and here you can see the path-CR rate for patients that did go to surgery was 30%. And it seemed that the addition of nivolumab to chemotherapy was more favorable in terms of increasing the pathologic complete response difference across all of these different subgroups by stage, so including the stage 1Bs to 2s, 3As by histology. It seems like there was perhaps more of a benefit among patients with a history of tobacco use, although the never smoking population was relatively small with 39 patients. And interestingly, there was a benefit to the addition of nivolumab, both in the PD-L1 negatives and the PD-L1 positives, and regardless of TMB with this single cutoff of 12.3 mutations per megabase. The choice of neoadjuvant chemotherapy of cisplatin or carboplatin also didn't seem to make a big difference. And I think what we'll be very eager to see during Monday's presentation is, do all of these path-CR subgroups hold up for the event-free or disease-free survival? And here, very impressively, you can see the pathologic regression, the depth of pathologic response was much higher in patients that received chemotherapy plus nivolumab, with an impressive number of path CRs as well as major path responses. And you can see how poorly chemotherapy alone does in the figure on the right. Importantly, we see that the path CR rate was increased with the addition of nivolumab regardless of stage. So here you can see the stage 1B, 2A, 2B, and 3A, and impressive increases in the path CR rate across these different stages, although again the subgroup numbers are relatively small across these different figures here. How well is this tolerated? And you can see there are, of course, some concerns about giving immunotherapy in the preoperative setting and raising the question of a serious immunologic toxicity or an IRAE, but you can see, generally speaking, the rate of high-grade adverse events was very comparable between the chemo-nivo arm as well as the chemotherapy arm. And in general, this type of regimen, I think, in the metastatic setting and as well as the early stage setting is relatively well tolerated for patients. Now, how can we use information to really help understand which patients will need more therapy? What will we understand going into surgery about the risk of finding residual disease at the time of surgery? So this is looking at CTDNA clearance prior to surgery. So this is looking between cycle 1, day 1, to cycle 3, day 1. So this is before they go to surgery. And you can see that among patients who have chemotherapy plus nivolumab, there was a higher CTDNA clearance rate. And among patients with CTDNA clearance, you can see that those with clearance had a higher path CR rate, and those without CTDNA clearance, whether it was chemotherapy or chemo plus nivo, were very unlikely to have a pathologic complete response rate. So while we don't use this currently in routine clinical practice, I think using CTDNA going into surgery will give us some hopeful indication of what the surgeon might expect to find, since the imaging, as Dr. Spicer said, doesn't really always track with what our surgeons will find or what our pathologists will see under the microscope. And you can see that in terms of the type of surgeries that our patients received, that those who received nivolumab plus chemotherapy versus chemotherapy alone had numerically increases in minimally invasive types of approaches and a lower rate of conversion to open thoracotomies here. And importantly, as we are all concerned about the risks to a pneumonectomy, numerically there were fewer pneumonectomies in patients who received the combination of immunotherapy plus chemotherapy. So it seems that incorporation of immunotherapy doesn't per se increase surgical risk, and if anything, may lead to more favorable types of operations. And we'll be interested in discussing this during some of our case discussions at the end. When we look at the complication rate in the 90-day window after surgery, again, we're not seeing any significant increase in either low-grade or high-grade adverse events in the postoperative period among patients that got immunotherapy. So again, very comparable and favorable side effect profiles, both in terms of the more common and less common side effects as shown here. Does this increase hospital stay? No, and whether you're looking at North America, where there's a very short hospital stay, or Europe and Asia, the addition of nivolumab to chemotherapy did not increase hospitalization, and in fact, if anything, may have led to shorter length of hospital stay. This regimen is now FDA approved. We haven't seen the data in detail publicly yet. There's one figure in the FDA package insert shown here, which is the event-free survival in the intention to treat population. You can see an impressive hazard ratio of 0.63 with a median EFS of 31.6 months in the nivolumab chemotherapy arm and 20.8 months in the chemotherapy alone arm. So we'll all be very eager to see this oral presentation on Monday's session to see how these subgroups will really play out. And I think an important question for us, this regimen is now approved regardless of PD-L1 status, regardless of parsing down the stages. So we'll really need to see, are there certain subgroups that benefit with this regimen more than others, or do we see an equal benefit for event-free survival as was hinted at with the pathologic complete response rate? And this was a very recent approval, and we're all currently working to incorporate this and build the chemotherapy, immunotherapy order sets for our patients so that we can administer this as rapidly as possible in routine clinical practice. But the study raises many remaining questions, so we'll be looking to see these questions with Monday's presentation. So how does the regimen perform in different subgroups? For the PD-L1 negative populations, the low positive or high positive, is there an impact of smoking status, stage, does this work equally well in squamous and non-squamous? And then what will be the relationship between major pathologic response, path response, and event-free survival? And a really important question to accelerate drug approval in early stage lung cancer is, like in breast cancer, can we start to use these as surrogate endpoints to rapidly lead to new drug approval, or will we need to wait years to see the event-free or overall survival readouts? How closely is CTDNA clearance before or after surgery associated with EFS? And again, can we start to incorporate additional measurable biomarkers for our patients? What we don't know, are there certain molecular subtypes that benefit more or less with this regimen? So we'll talk a little bit about EGFR and ALK, but there are now many genomic subtypes of lung cancer, and even within molecularly defined subtypes, there are co-mutations that may impact the efficacy of immunotherapy. One example is KRAS mutant lung cancer. Some KRAS mutant lung cancers can do extremely well with immunotherapy. However, co-mutations in genes such as STK11, KEAP1 predict for worse responses to immunotherapy in general. So we'll need to start parsing out these subgroups as we learn more information about our patients and their cancers. And can we overlay other biomarkers, as Dr. Peters said, such as tumor mutational burden, immune cell infiltration, certain other immune checkpoints or activation markers? And really an important question is, who needs adjuvant therapy? And what is the best regimen depending on the pathologic response? So we saw a number of the trials not only are incorporating neoadjuvant immunotherapy, but extend that adjuvant immunotherapy for 1 year out after surgery. And does everybody need that? Are we giving too much treatment to too many patients, or can we further refine which patients really need that extended duration of treatment after surgery? And we're seeing some differences between trials. It's always difficult to compare, but as Dr. Spicer said, the pathologic complete response rate was different between the NADIM study as well as Checkmate A16. There were slight differences in the regimens, the populations, but I think we'll really need to refine our understanding of some of the differences that we may see between trials, which we'll come to as we talk about some of our adjuvant studies next. So now what about adjuvant therapy? And this was approved already sooner than the neoadjuvant study, so we're all familiar with the phase 3 Empower 010 study. And I think an important piece to mention, as Dr. Peters was mentioning, is that where does the randomization occur in neoadjuvant versus adjuvant studies? So in this trial, patients had to have already had their resection. Patients with EGFR and ALK-positive lung cancer could enroll, and patients had to have had at least one cycle of chemotherapy. So as Dr. Spicer said, there is a lot of drop-off in standard of care, patients not getting to surgery or patients in the post-operative period not getting adjuvant chemotherapy. There's a large fraction of patients that will never get to this point. So this is a pretty selected population. Everybody who was randomized to receiving adjuvant atezolizumab or best supportive care already got through their surgery, they recovered, they were strong enough in the recovery period to receive at least one dose of adjuvant chemotherapy at the time of randomization to immunotherapy or best supportive care. So when we look at the general outcomes of this population, even in the control group, they tend to do much better than what we're seeing in some of the neoadjuvant studies. And you can see that the patient characteristics were relatively balanced between the atezolizumab and best supportive care arms based on, again, the histology, the PD-L1 status, the lymph node involvement, the type of surgery. And importantly, shown here is the disease-free survival in the PD-L1 tumor cell positive at 1% or greater, PD-L1 expression in the stage 2 to 3A populations, and you can see improvements in disease-free survival in the PD-L1 positive populations in particular. As you look through the different subgroups in the stage 2 to 3A population among PD-L1 positive tumor cell expression, again, you can see in general that patients seem to benefit with the adjuvant atezolizumab regardless of factors such as age, sex, performance status, tobacco history to some extent, as well as looking at some of these other subgroups of stage, lymph node involvement. Importantly, it seems that among the smaller subgroups of patients with EGFR or ALK rearrangements, there seemed to be less of a benefit to immunotherapy, which is what we have learned in the metastatic setting, although again, the subgroups are relatively small in these population studies here. Again, similar findings in the all randomized population, and I'll draw your attention to this tumor cell expression as we look at the PEARLS study next. We do have a sense in the metastatic patient population that the higher the PD-L1 level, the greater the expression, the better the outcomes to immunotherapy, and that was borne out in this adjuvant study as patients with very high PD-L1 expression of 50% or greater seem to do even better. If you exclude the EGFR ALK patients, again, you'll see an improvement in disease-free survival across various of these PD-L1 subgroups. Importantly, again, looking at the PD-L1 50% population, you see a nice separation of the curves here. And again, looking through the different treatment characteristics, again, these subgroups do raise questions when we see patients in clinic. If I see a node-negative patient, does that mean I should or shouldn't give atezolizumab? It's hard to integrate many of these factors together, such as stage, node involvement, PD-L1 expression. But in general, we use adjuvant atezolizumab based on the approved indication. Again, we're seeing CTDNA as a good readout for outcomes in the adjuvant setting. So in patients who were CTDNA positive, the adjuvant atezolizumab did improve outcomes, but this was the patient group that was at highest risk of recurrence. In the CTDNA negative patient population, again, there was an improvement with atezolizumab, but in general, this was a more favorable population after surgery. We just saw this update about a week ago at the European Lung Cancer Conference. Again, just focusing on this PD-L1 subgroup population of 50% or greater, whether you include or exclude the EGFR ALK populations, again, a very sizable difference and impressive hazard ratios of 0.43 and 0.43 in both of these curves here. In general, this is a safe regimen, although there are side effects to giving adjuvant immunotherapy, again, for about a year, and there can be some side effects that emerge over the course of treatment. In terms of the rate of immune-related side effects, again, relatively low risk, but there are some side effects that can be quite bothersome for patients. So again, it's important for us to really understand, do all of these patients need adjuvant immunotherapy, or are there some patients that will be cured with the surgical procedures alone? And again, the OS data, as we've seen, is not yet fully mature. We're starting to see some separation in the curves in the PD-L1 positives, but we'll have to follow this further out with longer follow-up for this patient population. And we know that this was also recently FDA approved in October of 2021. We've recently seen the phase 3 KEYNOTE-91 study, also called PEARLS, and this was a similar study of not atezolizumab, but adjuvant pembrolizumab, and this was a blinded phase 3 study, a fairly similar design here of 1 year of pembrolizumab versus placebo after patients underwent surgery. They did not have to receive adjuvant chemotherapy, although it was strongly recommended. So some of the patient population here, which was a difference between the PEARLS study and the Empower 010 study, some of the patients here did not receive any adjuvant chemotherapy. And that's shown in this table here. About 14% of patients in both arms didn't receive any adjuvant chemotherapy. But in the overall population here, which includes PD-L1 positive and negative, you do see an improvement in disease-free survival with a hazard ratio of 0.76. Interestingly, and this left us all scratching our heads a bit, in the PD-L1 high population, TPS 50% or greater, there was really no difference between those who received pembrolizumab versus placebo. And I think there are many questions, about the patient factors within this subgroup. Was there some issue with the randomization? Were there some patients that had very high PD-L1 levels of 90% more in one group than the other? I think we really don't know what accounts for this finding. But again, you can get a sense that across the different subgroups that in general, pembrolizumab did better than placebo, although in some of the molecular subtypes, I think the subgroups were relatively small here that we'll need to see how this bears out in larger populations. Again, fairly early, but we don't see a clear separation yet in overall survival. And similar to adjuvant atezolizumab, the adverse event rate was comparable, although some higher rate of adverse events, grade 3 to 5 in the pembrolizumab arm, higher rate of treatment discontinuation, as you might expect with 1 year of therapy after surgery. So to conclude this section, certainly the use of immunotherapy in the perioperative management of resectable lung cancer is a major advance for us in the treatment of this disease. Which patients should receive neoadjuvant versus adjuvant immunotherapy, or should some patients receive both immunotherapy before and after surgery? It's a big open question for us. And I think, as always, we need additional biomarkers to really understand and refine the treatment selection for patients with resectable lung cancer. So we'll wrap up with this same challenge question and then get to some cases. So based on what you've just learned, how would you now rate your knowledge and understanding of the data from these key phase 3 neoadjuvant studies in resectable lung cancer?
I announce the cases.
All right, great. Perfect. Well, I think we'll go through some cases, and then we certainly want to take questions and discuss questions from the audience. So we'll move on to the next slide here.
This is not intuitive. It's very difficult to try to understand how this movement of knowledge are really reading. But anyway, we trust it's better afterwards, right? It's a distribution, right? It's supposed to reduce on the left, increase on the right. So we have 3 cases we'd like to go through. The first 2 will be presented by John. There are questions in the middle which are very important for us because they are not black and white. It's really questions that we have in our minds too. And it's going to be very important for us to know what's your point of view, wherever you come from, to answer this very difficult question. So please go ahead.
Thanks, Dr. Peters. So I picked this case because it's a bit of an extreme case, but I think it illustrates some interesting features of what can be achieved and some of the challenges that we still have to face. So He's a 48-year-old man who's an active smoker. His ECOG is 1 when he presents. He presented with a very large tumor. You'll see a picture of the PET in a moment. He was staged by CT, PET, EBUS. I say N+ because the tumor had essentially coalesced with N2 and 1 nodes. It's just one big mass. He had, the diagnosis was non-small cell lung cancer not otherwise specified with a PD-L1 of 90%, and there were no driver mutations from the pretreatment biopsy. He has lung function that's adequate for a lobectomy, I guess. It's also a little borderline, but not much functional lung in that upper middle lobe. He presented with this SVC syndrome and right shoulder pain. We did brain imaging by MRI that was negative before treatment. So start with the question of what you would do for this patient. A lot of different options for these folks. Not sure which one's the right one. So I'm not sure that we get to see the results. What's 6? Neoadjuvant chemo. Oh my goodness.
Oh, wow.
I guess we convinced you guys. Which one of you is taking him to the operating room? Okay, so that's very interesting. So, well, he ended up receiving chemo immunotherapy. This was off protocol. We basically called him unresectable stage 3 in order to get access. We have to do these little tricks in Quebec to get access to some of these drugs. And then he went for an additional. So this is his interval scan after 2 doses. And you can see a necrotic area emerging in the middle of the tumor. Here's another shot. And what encouraged me to offer him an operation is you can see there's a nice plane with the trachea. This is the first branch of the pulmonary artery, and there's a fat plane there too. So it's feasible to do a lung-sparing operation where you could preserve the lower lobe. The phrenic you can see is already out, and I'm not showing you the picture, but the SVC is completely occluded. He's recanalized. All these vessels here are collaterals that, we can resect the SVC without consequence for this patient. So part of the concerns were whether the ribs were involved, the artery might have been involved as well. Anyways, these were all concerns we had going into surgery. But there's clearly partial radiological response after these courses. There was a timing issue. He lives 3 hours out of Montreal, so OR time, COVID surges. We gave him an additional cycle of immunotherapy to assist. This is one of the nice things of having a patient on neoadjuvant treatment, is you can adjust. And so that's the remainder of his imaging. We ended up taking him for surgery, sternothoracotomy. Lost about 1 liter just opening the chest. There were so many collaterals, but once we got that under control, we were able to do a nice en bloc resection. We had surprisingly good planes on the PA. No need for any angioplastic reconstruction. I was worried that the ribs were involved. We sent multiple frozen sections. Everything was coming back negative for tumor, so we left the ribs in place. I was convinced I was going to have to do a bronchial sleeve. Bronchial margin is negative, so we didn't do that. This is his post-op x-ray, a month and a half out. I won't minimize how difficult his post-operative course was. He ended up going to the ICU, getting intubated. He had profound hypotension, which ended up being steroid responsive, and one wonders whether he had a bit of an adrenal suppression from an immunotherapeutic complication. Ultimately, he went home and he had a good course. So kind of a crazy case. Raises some questions. I don't know what you guys think.
Maybe I might ask, if we heard this patient had a PD-L1 level of 90%, if it was 0%, would that have affected your comfort with this kind of approach?
Yeah, well, that was actually discussed at the tumor board at the onset, and I think it was his age, his functional status were all kind of things that are pushing us in the direction of trying something like this. And I think the PD-L1 certainly influenced us at the beginning.
It's probably strongly dependent on the institution you work in, because this case in majority of institutions would have been deemed or considered as being non-surgical by definition at initial diagnosis. So that's also maybe the time to re-question the definitions of resectability and operability consequently, based on the data we will produce in the next clinical trials, maybe not the current ones, but it's interesting to see that it's way beyond what you can expect in terms of resectability. You could go to an RDO without even needing a sleeve, so it was not expected.
No, it certainly wasn't expected, but then I wonder, could I have avoided the operation entirely, and maybe a radiotherapy consolidation there would have been adequate for this patient.
You want to show the pathological response?
Yes, sorry, I forgot there's more.
Yes, that's important, because it's for my next question.
Right. So yeah, what came out, I just assumed that you guys knew. The tumor comes out, it's massive. It's a large area of necrosis. There's a rim of inflammatory cells at the edge of the tumor. The innominate vein is marked by fibrosis that was involved originally. And the final path is YPT0N0 with an 8 centimeter necrotic bed. So, that's why I'm saying maybe he was cured. He didn't need all this stuff.
Yeah.
So that's
the main question
case.
here we discussed just before coming here to the stage. Would you continue? Because there are pro and contras, right? Even melanoma colleagues, when they get a complete response in metastatic disease, which is a way better circumstances, they continue a little longer the immunotherapy. So here, after this surgery, what is the risk of still having some metastatic disease? And did you expose sufficiently your patients to IO to be satisfactory? Even in a micrometastatic disease, do you think it was enough? So it's a big debate. Would you continue for an additional 3, 6, or 8, 9 months to go up to a year or not? It's intuitive, right? I would have said yes, and I know you probably.
Well, it's not my decision to make. I don't prescribe these things. I was sort of pushing for it at the post-resection tumor board. Yeah, I hear different things from my medical oncology colleagues. So some will say, "Oh, he's had a great response. We should keep giving more," and others like, "Oh, he's got a great response. Maybe we're done." And I think it really speaks to how little we know.
You don't know.
How did it make
Mark, what would you have done?
Yeah, it's a great question. As looking at these trial designs of this sandwich approach of immunotherapy before and after surgery, they're all compared to chemotherapy alone and placebo, and so we don't really have the answer to this question. I suspect the next wave of trials will be looking at this very question in patients that have neoadjuvant chemoimmunotherapy who have a path CR. Can we randomize patients? Will patients and their providers feel comfortable randomizing in the postoperative setting to continuation of immunotherapy or not? Do you think those trials will need to be run to answer this?
They should be run. But there are many trials in the field of immunotherapies that were never performed because of feasibility, duration, and marketing issue, right? Usually there's only one trial, the 816, which doesn't give rise to any continuation. Would the 3 other read positive with up to 1 year of immunotherapy, like in GI, like in breast, and so on? I'm not so sure that a pharma industry will invest in trying to show that less is better. Mm-hmm. That's usually not the case. So it should be an academic trial. And unfortunately, imagine the statistical design, you will need a lot of patients to show the difference. It might be important, but it will be a trial which has to last for a while because of no surrogate endpoints. Mm-hmm. So I hope so, but I'm unsure.
Yeah, maybe the biomarkers, the CTDNA will be a better guide. Shall we go on to the next case? Mm-hmm. So this is another patient, 71, older gentleman, ex-smoker, 50-pack year. He comes in with an ECOG of 0. He has this lesion, which you see highly active, avid on PET, that is biopsied and comes back as a squamous cell carcinoma, PD-L1 90%. We clinically stage him as a T3N0. He has actually good lung function. We do a quantitative VQ scan, and the left lung has contributed 35%. So how would you guys approach this patient? Do we have a slide to ask that question? No. So we ended up putting him on chemo IO. And you can see this is the post-treatment scan. There's still disease. The tumor has sort of retracted off the pulmonary artery ever so slightly, but it's clearly into the wall of the pulmonary artery, and one would have to do an arterioplasty to try and save the lower lobe. So then the question is, he's had a bit of a tough course with the treatment. He's a bit reticent to go to surgery. Are there other options? What do we do for him?
How much do you trust your CT scan? Think about your first case. You have a CT scan with maybe a very tiny shrinkage here, but the other case you've presented before was a PT0, PN0, but still you had 20 centimeters on the CT scan.
Right, yeah. It's so tough, and this is what I'm talking about, the black box that we have. This patient ultimately chose not to go to surgery. I think he was a bit worn down, and I told him it was sort of, I didn't mind doing the operation. I was open to it. These are fun cases for us. but I think he was a little reticent and ended up choosing to go for RT consolidation. You know, he may have had a great response to treatment. There are concerns for me for radiation in a central lesion like this. What's the heart spread? Is there a heart dose there that's significant on the medium to long term? So we're not sure what the right answer is. What would you guys have done with this scenario?
Yeah, it's a great question. It just speaks to the need for other imaging modalities. I think a PET scan wouldn't really be helpful here. It would likely light up just as much, whether it was malignant or an inflammatory response. So, you know, I think, again, the patient preference here, you know, hopefully, again, with this very high PD-L1 level, hopefully he can do well with immunotherapy and radiation. So.
So maybe we should take some time for the questions.
Sure, yeah.
But just because we have not so much time remaining and there are lots of questions, but maybe here just to continue, because one of the questions is about radiological response, right? We've been working on that under immunotherapy. Of course, we use for this kind of cases something like the measurement according to RECIST. We tried also across each trials to use modified iRECIST, but they changed in each trial and were never really standardized and are not applied. So my question to you is, you have this experience of neoadjuvant chemo IO, but you have shown us very nicely that at least on the CT scan, it doesn't look to correlate, or at least you don't let the time to correlate with the pathological response. So would it be true to say that if you start such a strategy, if you don't face, I would say, a new set of lesions, even a local growth might not discourage you to go to surgery? What I mean here is, should you try to close the eye in front of the local evolution and go to surgery, provided there's no new lesions or distant mets?
So yeah, I think it raised the question of invasive staging by a mediastinoscopy or EBUS. I've not been a proponent of that. The first patient I put on, first trial ever, was an Ipi-Nivo patient when 816 was open, and he had a huge mass in the right upper lobe, and it grew, and I was very concerned. But he had a decent response, and most of the time, I mean, these are just specific cases, but the vast majority of the time we take patients to surgery. It's very uncommon that they get a progression that leads to non-resection or that would prevent me from going.
And that's quite difficult because in metastatic disease, usually we use the clinical parameter, how the patient is doing. But in the pre-surgical setting, I'm not so sure that this parameter is valid, right? It's too short time frame, it's still an early disease, you still have on-site ventilation limitations, so I don't think you can rely on anything really currently.
And the whole concept of all the patients who are put on these trials is that they should be operable at presentation.
Yeah.
So we're not trying to make people operable necessarily. I don't want people to get the wrong message.
So I have another question, maybe Mark, you will take it first. In terms of biomarkers, we've been seeing in lung cancer, also in other diseases, that maybe one still exists and is reproduced over time is a PD-L1. Not consistently, maybe at the time being not in Pearls, but in IAM Power 10, and in Checkmate 816, we'll see it on Monday. But my question to you is, if you go into the strategy of neoadjuvant, chemo IO or IO, do you need PD-L1? And would you have the courage to skip the chemo if you have a high PD-L1? And the second question is, what other biomarkers do you ask your pathologists to get? Only PD-L1?
It's a great question. You know, I think despite all the progress we've made in immunotherapy for lung cancer, we don't have that many clinically available biomarkers, and we also don't know exactly how they perform in the metastatic setting versus in the early stage setting. We know in general for stage 4 patients, they tend to have higher PD-L1 levels on average than the early stage patient population. But it's a great question. If you had a patient like this with PD-L1 of 90% or 95%, can you spare them the chemotherapy portion of the neoadjuvant therapy? Can you just use immune therapy alone? And we don't have too many trials. There have been some trials of neoadjuvant atezolizumab alone or nivolumab alone, and On balance, we don't see quite as high complete response rates as compared to using chemoimmunotherapy. So I think likely to get the best response possible, even in the PD-L1 high population, we likely will be moving forward with more chemoimmunotherapy combinations. If there's a rare circumstance where there's a contraindication to chemotherapy, maybe in talking with our surgeon in multidisciplinary care, perhaps there are some select circumstances where you might use immunotherapy alone and then get them to surgery.
And other biomarkers? Do you
Other
ask about
biomarkers,
you ask for the microsatellites, STK11, we think about it in lung, or even the TMB?
I know even in stage 4 lung cancer, we don't incorporate a lot of other biomarkers, which is a challenge for us because we see such variation in the outcomes. You have two patients with the same PD-L1 level, both KRAS mutant, one does well, one doesn't. We don't really understand. So, we would love to have several of these biomarkers like quantitative immunofluorescence, looking at TIL infiltration or immune cell subsets, TMB, et cetera. But I think we're just too early to know in the early stage setting as to how these additional biomarkers may or may not impact our long-term outcomes.
Maybe one question to you, which was asked by someone from the room, is at the end of this debate, I remember in the phase 1-2 setting of neoadjuvant immuno or immunochemo, there was this suspicion that there was this fibrotic kind of issue, more difficult, surgery was longer. So can you make a final point, because you performed many surgeries on this patient. Is it like after radiation at a certain time of waiting, it's difficult to perform the surgery? It's easier? Is there any difference for a surgeon?
Yeah, so I think Checkmate 816 shows that there isn't really, on average. I think by and large operations for locally advanced lung cancer after induction are difficult operations. And I do think the timing is relevant. A lot of the early reports, surgical reports, were consolidation treatments for patients who had been on many months of IO, and I think that certainly induces a different kind of fibrosis that affects the surgery than a patient that you've done a planned operation 3 or 4 weeks after completion of 3 or 4 doses of treatment. I think those are really important factors. The inflammation is still fresh. It's easier to dissect, and it's borne out in the data that it's, operations were shorter. There's no real reason why they should be shorter other than easier.
Even easier.
Yeah.
And in the setting of neoadjuvant or adjuvant IO, the main questions that will come in some months from now, maybe already present in your institutions, you've been performing this trial, is what is the impact of this early stage immunotherapy? We know it also from the stage 3 somehow, to the impact for subsequent treatments while the patient relapses and you have to face a metastatic disease. What is your institutional kind of guidance there? Do you have a kind of an interruption of immunotherapy that makes you think that it's still worth retrying or rechallenging? What do you do on a daily basis? Rechallenging IO.
This is a really challenging question for us, and there's so much variation in when the recurrence happens and the pattern, anatomically or radiographically. So I think one question that we've been asking in the kind of Pacific era of consolidation immunotherapy for 1 year is, did they progress while on immunotherapy or after the completion? And I think we'll be asking these same questions in the early stage resectable setting. And if they progress while on immunotherapy or shortly after discontinuation, and if it's just a single site or a single lymph node, can we use a local therapy such as radiation or surgery? Is that curative, or are you exposing patients to unnecessary types of procedures without helping them in the long term? So these will be really important questions for us to ask and address. Are they having oligo recurrence or oligoprogressive disease? Is it while on immunotherapy? Is it 2 years after the end of immunotherapy, in which case you might retry an immunotherapy or chemoimmunotherapy approach? So there's a lot of variation, and we have small retrospective series that show that there's a lot of different practices going on out there.
The CT has defined 12 weeks as being potentially defining early relapse versus late relapse. Would you consider that beyond 12 weeks it's worth retrying IO if you have stopped for more than 12 weeks?
I think if a patient has tolerated therapy well and they're not, their disease isn't running amok or exploding, then I think it could be worth a try if you felt like there was some benefit. But again, I think we don't really have a good understanding of even immunotherapy resistance, and these are important studies for us to do. Are these cancers that will lose some of the antigen presentation machinery, HLA class 1, beta-2 microglobulin, et cetera, in which case they may not respond to immunotherapy, or right now we only have a few small case series of immunotherapy resistance, and we don't really understand that biology.
Last question, then we're already a little late to you. I've seen your wonderful immunofluorescence, right? And the question is, if you would like to maybe work less in the future and find the biomarker allowing you to confidently kind of delay or observe, we start to see it in some other malignancies, try to give up surgery in patients having high PD-L1, receiving neoadjuvant chemo IO. Do you think there is a parameter by, as you say, restaging or reassessing the disease, circulating DNA, immunofluorescence, any kind of biomarker which at some point might make you potentially renounce to a local treatment and go to a wait-and-see strategy? They do it now, nothing with immunotherapy, but they do it now in colorectal malignancies?
Yeah, absolutely. The logo at MD Anderson, where I trained, has that line going through the cancer. I think unless you're trying to put yourself out of business, you're not trying hard enough. So hopefully I still have a bit more time because I like what I do. And I think there'll always be a place for thoracic surgeons. But I think that's certainly the direction we have to go in.
Mm-hmm. Thanks a lot. I guess we covered more or less all the questions. There were some more, but thanks a lot for the participation. I think I don't know if you have any final slide, maybe a final vote. I have to make sure. Oh, yes, I missed it. No, the question. I don't know if there's, yeah, this one we have to, I think, question at the end to end this meeting. Based on what you just learned, how would you now celebrate your skill and confidence in making clinical decisions regarding the whole neoadjuvant and adjuvant immunotherapy? From 1 to 5, please vote. It's going to be the last one, I guess. I hope. It's difficult to self-evaluate. Very difficult exercise. Okay, so I think it means it's good because it's go down on the left and up on the right. It has to go like that. Thanks a lot to all of you for your participation and asking questions and to be here. And I wish you a very nice congress and a nice evening. Thank you.
Thank you.